Okay, now we can, these presentations are open for questions. Yes.
Quick question. Did you try to correlate those biopsies, like this gene signature, with complete versus incomplete type of gastric intestinal metaplasia?
Well, interestingly enough, about half of the components are things that have been verified from a variety of studies, including gene expression, RT-PCR, and immunohistochemistry. And some of this data actually been identified, overlapped with some of what's been reported from the Vanderbilt groups that are interested in this. So we do know that we have external validation based on published data that a good portion of these overexpressed genes in particular have been verified.
I see.
Any other questions?
I have another question, sorry. So for Dr. Constanza, for Dr. Camargo. So I think it's really challenging. This morning we discussed that the challenge of doing biopsies on people with hereditary diffuse gastric cancer, because we can't really find those cancer, obviously, on endoscopy. So I think the biomarker will be a really good tool to identify those. Have you been planning to do something to correlate the yield of using biomarker to diagnose or detect cancer early in those patients with hereditary diffuse gastric cancer?
Let me see if I hear correctly. So you want to know if we have been trying to differentiate between diffuse and intestinal, right?
Well, I think that's the tool you're using actually will be an excellent tool to risk stratify patients with hereditary diffuse gastric cancer, because it's really hard to find those tumor cells with endoscopy. But they may have circulating microRNAs in their blood way in advance. So you can use your tool to find those people early to decide whether they need total gastrectomy or not.
Yeah, I think that at this moment we all are trying to identify the biomarker for gastric cancer overall, and then if the data are available, we will be stratifying by diffuse and intestinal. Yeah, but my personal interest, more than the marker for gastric cancer, I'm very interested in a marker for intestinal metaplasia, because I think that the hope for Eastern European countries and Latin American countries is intestinal metaplasia. So we need to try to see how we can identify in a more efficient way those individuals with intestinal metaplasia, and then follow them over time, the high risk for the development of cancer, and hopefully to try to identify gastric cancer early, because it's unthinkable, the possibility of doing a screening in everyone, as the beautiful screening programs that are in Korea and Japan. Thank you.
So I'll ask Han Lee. Most of these are genetic markers that are coming out of tissue. So is there any likelihood that you might find them shed into the blood, or maybe possibly into the stool and pass to the gut?
Yeah, we're working on something regarding that to try to better measure that type of signal. Some of it is a little more genomics and flavor, partly because other than a handful of genes, somatic mutations really don't prove to be very informative. So it seems like the arm imbalances, which are probably one of the best precursors for identification. And I'm starting to hedge my bets that there are probably variations in certain epigenetic patterns, albeit they're not as specific that we can draw out. And so we have a new strategy to try to do that, and early gastric cancer detection is definitely on the list. And we've demonstrated that it works in another major malignancy. So I'm hopeful that this kind of more genome-wide strategy could prove to be really useful.
Would you expect, though, to see the actual cell types, precancer cell types, metaplasia, sloughing off and able to pick up?
I think that's very dependent on, there are a couple of ways to do that right now. MicroRNAs certainly are, I've seen some of that data from the Japanese groups over the last couple of years. It seems to be fairly convincing. So separately from that strategy, I think part of the issue with trying to gain a signal is to ensure that it's represented across enough aberrant events to that aberrant epithelial cell population that gives you, as a collective summary, enough of a signal boost that you can get past the fact that it's represented fractionally in only a small proportion of the amount of analyte that you get from plasma. So you're depending on a lot of events that are happening, say if it's an arm imbalance, which are starting to go awry, but that's enough to give you a signal boost as a summation across that you can see that and see that signal amongst all the normal plasma DNA that may exist.
So I guess I said it. I'm thinking more in a stool sample because, it's really still concerning about colon cancer, whether we're going to pick up anything in the blood, because it's for the early stages, it's so easily sloughed off into the colon. There's room for it to expand and slough off versus into the blood system because it hasn't really invaded anywhere. And so in a gastric system, is it dissimilar? You might pick up things.
Yeah, I think early gastric cancer is going to be just as difficult as early breast or early colon. So there's clearly a stage-specific reduction in sensitivity. The question I really have, and the gastroenterologist will know this better, is, you're going through a much longer transit time, right? And so if you have a particular protein candidate that you're hoping gets retained through a stool portion, can it get through the denaturation, the acid, the proteases released by the pancreas and whatnot to actually make it out? I don't know, that seems kind of hard, but we'll see. So,
I wanted to ask Dr. Lin a question. Dr. Lee, sorry. On your spatial transcriptomics, is it one of the commercial platforms like Geomics or Visium, or which one are you using?
Yeah, I'm primarily using Visium.
Okay. And so we've been looking into this for our Crohn's disease work, and maybe you can help me here. Our concern is that because it's this grid, and when we did single cell, we have the whole tissue that we've looked at.
Sure.
And our concern is that if we use the grid and it's just selected areas, that's not a good idea.
I think that that's where kind of this integrated approach becomes really useful, because if you have enough single cell data from Crohn's lesions, we know that the resolution for a given grid coordinate is about 5 to 10 cells, but that's still adequate enough signal that you can actually deconvolute the composition within a given grid. And so that's one of the tricks that Andrew and Ignacio and Anuja came up with to prove more cellular resolution of the cell types present within the grid themselves. Secondarily is that having worked with that kind of gridded DNA, I'm in the know that the resolution will probably improve over the coming year or two. So you'll have the benefit that will increase. And then thirdly, the fact that we ran most of those on FFPE samples and had the resolution with internal controls we expected to see, as well as cell-based identification, that gives us hope that this is a really informative way, particularly if you mix in other data sets. So the integration proves to be very useful to make the spatial even more informative.
Okay. If there's no last burning questions, we'll pass the baton on to our next group.
Thank you.
Thank you to the speakers.